Yeah, good afternoon, network. Are you able to hear?
Yeah.
Okay, thank you so much for that feedback. So you can see that we are still at 53 participants. So we hope that more people are going to join us. So we welcome you all to our today's meeting. So we can see that already we have Dr. Daniel Mwamba, who is already on the call. Good afternoon, Doc.
Good afternoon, Dr. Onoya. Thank you.
Okay. Kitwe Nursing School as well is connected. Good afternoon. Are you able to say something, Kitwe Nursing School? Kitwe Nurse. Okay, all right. Let me just I don't know if our experts are already on the call. Dr. Chanda, Chitalu Chanda, are you on the call, Doc?
Good afternoon, Doc. Yeah, I'm here.
Yeah, thank you for joining.
Thank you. Welcome.
Okay, thank you. Do we have Dr. Munthali? I'm not very sure, but is Dr. Munthali, Tendai Munthali on the call, please? And Dr. Mundia Mwitumwa, she's one of our experts. I don't know if, yeah, I can see that she's not yet on the call. So I would like to welcome you all to our today's meeting. Today we are going to I think the email was already shared, and our expert is already on the with us here. So I'm going to ask Dr. Teddy Kajimoto to introduce himself before we proceed with the didactic presentation. Doc, you are welcome.
Good afternoon, everybody. My name is Teddy Kajimoto. I'm a registrar of internal medicine here at UTH Adult Hospitals. It's good to be here.
Okay, thank you so much, Doc. Sure. Okay, so we are going to start with our didactic presentation. Then we follow the questions and answers. After that, we are going to have a case presentation from Kabwe and Hospital. Okay. So we are going to have a case presentation from Kabwe Women and Newborn Hospital. But before that, allow me to give chance to Dr. Kajimoto so that he can take us through the didactic presentation. Over to you, Doc.
Thank you very much, Chair. So today we're going to be looking at how we can approach STIs. I think the problem is actually there. Sometimes it looks us in the eyes and we don't actually see it. So I'm hoping maybe after a couple of things today, would be more convinced with how we can pick up some of the things that we can see. So our main objectives include to review the epidemiology, including trends of STIs in the region, to review clinical presentations for the most common STIs and how we can best prevent STIs, and discuss the screening, diagnosis, and management of common STIs. Okay, so these are just some of the common STIs that we have in our setup. So we have patients with herpes, syphilis, gonorrhea, chlamydia, trichomoniasis, genital warts, molluscum contagiosum, hepatitis B, HIV, and other STI complications. What is the global trend as far as STIs are concerned? So in 2021, the World Health Organization estimated that we have at least 1 million STIs being acquired daily. So every day, even today, from those stats, they imply that 1 million people are going to get STIs today at a global scale. When we look at the cases of chlamydia and gonorrhea with syphilis and trichomoniasis in people between the age of 15 and 49 from 2019, from 2009 to 2016, it is estimated that we've had over 376 million cases between that period. That again gives you an idea exactly of how much STIs we actually do have. Then as far as herpes is concerned, it is estimated that at any point in time, if you could get a snapshot at any point, at any one point, you have at least 417 million people infected with herpes. As far as HPV is concerned, about 291 million women are infected with human papillomavirus at any time. So that really tells us that there's a large job as far as STIs are concerned. And we have 70 to 90% of genital discharges, patients that present with genital discharges due to chlamydia and gonorrhea. So we find that most of these discharges are actually accounted for by chlamydia and gonorrhea. And one thing that we've actually noticed is that there's been a lot of change in drug susceptibility patterns for gonorrhea just in the last few years. So already this tells you that there's really a problem, and I think the onus is on to us as clinicians to try to reduce these stats as much as possible. The epidemiology in Zambia that we have is that gonorrhea is the most common STI causing discharges. In male, that's like 70%, in female, it's 64%. But you can also have other features of non-gonococcal urethritis and sinusitis being common themselves. I think as we go in the presentation, we're going to pick up one or two things on that as well. HSV is also a cause of genital ulceration, and syphilis is detected in 6% of patients that actually have ulcers. As far as genital warts are concerned, at least 70 to 80% of individuals presenting to the STI clinic at UTH actually do have them. This is just a trend showing the increasing number of STIs in our OPDs from 2017 to 2021. And we can see that there's been a significant steady rise in STIs, or perhaps it could be a reflection on ability to actually detect them. But what we can say is that we do come across STIs in our population. So what is needed is for us to actually diagnose patients. So I think at this point, before going further, we can launch the first 4 questions.
Okay. So we are going to launch our first 4 questions. Okay, are you able to see the first 4 questions? Can you get a feedback from the network? Are you able? Okay, we can see that people have already started voting. Can continue voting. So, which of the following STIs is prone to drug resistance? And gonorrhea, trachomatis, human papilloma virus, and Onema pallidum. So we are going to end the poll now. Okay, so we can see that 69% of the participants has gone for the first option.
Okay.
Yeah. Then 14% have gone for option D. Last answer. Yes, over to you, Doc.
Okay. I think you can just click on share result.
Okay.
So that's good. That's the first 4 questions. I think the majority wins this case. We can launch the second 4 question at this time. So we have another question. Can you launch the poll? Genital ulcers resulting from STIs are mainly caused by which of the following? Stop sharing. Oh, it's the second poll. Okay.
Okay, so we encourage every one of us to vote. Thank you for those who have already voted, but we can see that more people are still voting. So genital ulcers resulting from STIs are mainly caused by which agents? Human papilloma virus, herpes simplex virus type 2, Treponema pallidum, Phyllis tucrane. So we are soon going to end the poll, I hope every one of us has managed to vote. Okay. 5 more seconds before we end the poll. Okay, thank you so much for voting. So I hope you are able to see the result where you are. So we can see that 60% of the voters have gone for option B.
Yeah.
Yeah.
This was actually preempted in this.
Okay. All right. What do you do?
There's a third poll question.
And then a third one.
We can just stop sharing this one.
Okay. This is the one.
So that's the third poll question.
So the third one, genital ulcers resulting from STI are mainly caused by which other, I think this is second. Huh?
So the third one is on the next slide. Slide. That one.
Okay.
They've already voted. They've already.
Which antibiotic is currently suitable for treating gonorrhea in Zambia? Ciprofloxacin, fluoxacillin, ceftriaxone, cyclovir. So thank you for those who have already started voting. We can continue. It's good to see that the voting is progressing. 10 more seconds for the voting. Five more seconds. Thank you to everyone for voting. So, Dr. Teddy,
Okay.
we are going to end the poll now.
Yes.
Yeah, and share the results. So we can see that 59% of the participants have gone for ceftriaxone. Yeah. So is that the correct answer?
Yes.
Okay. Thank you. So,
thank you very much. It's been a good poll session. It's good to know that people already have some good background on STIs. So the question is, what more can we build on it?
Yeah.
Okay.
Yeah.
So the first thing we're going to look at is herpes simplex. So herpes is caused by DNA virus. There are many types. So you have HSV virus 1, you have HSV virus 2. Those are the many subtypes, but the one that will give you genital ulcers is herpes simplex virus. So patients that have herpes simplex virus, usually transmission is through disruption of mucous membranes. Patients can have it through sexual relations with them. One thing we have to notice about herpes simplex 2 is that it's a virus. So obviously, when somebody gets herpes simplex virus 2, the body is going to respond. There's always an immune reaction. And this immune reaction is mediated by our T helper 1 cells of the CD4 type. So you have production of gamma interferon, you also have production of interleukin 2, and that results in a lot of macrophages being activated to fight off the virus. That is why you're going to realize that most patients that are actually being evaluated for HSV, when a microscopy is done, with special staining done, you can actually see that most of them actually have an aggregation of giant cells as well. How can a patient with herpes simplex present? So patients with herpes simplex, I think most of the audience is going to be familiar that herpes usually presents with multiple painful grouped vesicles on the, that are found on the genitalia. And the description is usually that these vesicles are also itchy. But one thing that we have to acknowledge is that even before these vesicles are visible, even before these vesicles have actually come out to be visible on the skin, patients still have symptoms before that. So most patients can have non-specific symptoms like headache, dizziness. Most of these patients can have fever. Some of them even have generalized lymphadenopathy. Patients can still transmit herpes simplex even before the vesicles are visible on the skin. So 4 days before the vesicles come out, the patient can still transmit herpes. And most of the patients actually complain of the genital itchiness, the genital pain, even before the lesions themselves are there. So if you are seeing a patient in the clinic who doesn't have a typical herpes rash or the vesicles themselves, but complains of genital itchiness, hotness, and has all these non-specific symptoms with a very suggestive sexual history, the absence of vesicles in themselves should not make us say that the patient doesn't have herpes. So that's just something that we have to remember. But the typical description is that it's painful. It's usually feels hot, itchy, and vesicular. One thing that we're going to appreciate about the herpes vesicles is that with time, they erupt and cause ulceration. So that's how the ulceration comes. I'm not sure if we can all appreciate the picture that we can see on the skin showing the genitalia with very hyperemic lesions that look like ruptured vesicles from a patient who has herpes. Most patients that have herpes also have patchy white deposits, especially in women. This has been noticed that most of them also have patchy deposits from within the introitus. So it's not something that should throw you off. So remember, you can catch herpes a bit early before the vesicles themselves are visible. You can catch it a bit late after the vesicles themselves have ruptured. It is still herpes. Treatment, we're going to start by saying that there is no cure for herpes. Once you get herpes, you have it for you. Why is that so? Because once you have the virus actually migrates through your nerves and resides in the ganglions, and it stays there awaiting reactivation. So what we can do is suppress the virus once you have an eruption. So suppressive therapy involves drugs like cyclova and valganciclova, which are antiviral. Valganciclova is newer and has less side effects, and I think better ease of administration as compared to a cyclova. So what we're actually saying is that once we give these patients these drugs, and these lesions actually go away and the symptoms improve, that does not necessarily mean that the patient has been cured of herpes. Remember, it lies dormant in the ganglion and can be reactivated by a couple of things. And one of the things that is that contributes to the reactivation of herpes virus itself is HIV. So HIV itself puts someone at having a higher risk of activation as far as herpes symptoms is concerned. Syphilis, I think most of us are familiar with syphilis. It's caused by the bacteria Treponema pallidum, which is a road-shaped bacterium. Okay. Transmission, I think everybody can agree that syphilis is transmitted most through sexual encounters, through sex and other intimate relations. Of course, men that also have sex with men can also have syphilis, and the presentation can vary in terms of the distribution of the rash and the distribution of primary syphilis. Syphilis itself, what really happens if somebody gets syphilis? So when you get syphilis, syphilis is going to affect the mucosa in the genitalia. Once it affects the mucosa in the genitalia, it causes endothelial damage. Then from endothelial damage, which is from the inside line of the red blood cells, it's going to cause what is called a perivasculitis. So it's going to cause some degree of vasculitis that can result in multiple end organ damage. In other terms, syphilis is essentially a vasculitis because the main pathology that we see in syphilis is a type 4 hypersensitivity reaction that is mostly seen around the blood vessels. Clinical features. Well, I think most people can appreciate that syphilis can be classified as primary syphilis, secondary syphilis, tertiary syphilis. Most people are familiar with primary syphilis, which usually presents with a painless chancre. Now, the chancre can be found in 90 to 95% of cases. The chancre is actually found on the genitalia. The classic description of the chancre is that it is painless and indurated. However, you can also have extra genital expressions of the chancre itself. So some patients can have a chancre on the lips. Some other patients can also have a chancre on their finger. So any suspicious lesion in a patient with a very suggestive sexual history that presents with a painless ulcer on the mouth, on the finger, and in men that have sex with men, you can even have the chancre around the anus, which is actually very common even among heterosexual couples today. So that's also something we can definitely have. From primary syphilis, you have secondary syphilis. Secondary syphilis comes about due to dissemination of the bacteria everywhere. And the typical presentation is that you're going to have a macular papular rash. Okay, that's the classic presentation of secondary syphilis, usually as a macular papular rash. Some patients have lymphadenopathy, some may not. Some patients may have alopecia, some may not. Some may have condyloma lata. Condyloma lata is just disfigurement that happens to the rash themselves because of the nature of the pathology. Remember, we were saying that in syphilis, you have involvement of the cell-mediated system as far as cell death is concerned. When we talk about tertiary syphilis, I think we're mostly talking about four main things. We're talking about cardiovascular syphilis. We're talking about neurosyphilis. Then we're also talking about cutaneous manifestations of syphilis. So when we talk about cutaneous manifestations of syphilis and the tertiary syphilis, we're talking about significant destruction of the mucous membranes, significant destruction of the skin, that is classically referred to in the textbook as guma. Now, a guma is just a point of necrosis attributed to a type 4 hypersensitivity reaction, which also results in disfigurement of the patient organs, and in most cases usually affects the face. When we talk about cardiovascular syphilis, we're talking about things like dilatation of the aortic root. So this is something that can be assessed by echo. So if you have a patient who presents with non-specific features of cardiac dysfunction, or you incidentally find that the patient has a dilated aortic root or an echocardiogram, this is a patient you can consider doing some syphilis lab tests. Another thing that is very common that we occasionally see, but never actually, sometimes never attribute to syphilis, is a thoracic aortic aneurysm. So as far as the cardiovascular system is concerned, some patients can present with an aneurysm. So if you're following a patient for an aneurysm and you find that this patient should have at bare minimum an RPR done just to make sure that you do not have syphilis. How does aneurysm come about? Like we said, syphilis is essentially a vasculitis. Neurosyphilis. The spectrum of neurosyphilis also varies. So most patients can present with a meningoencephalitis. Some patients can present with stapes totalis. Other patients can present with a stroke, which is usually ischemic in nature. And of course, other patients will also present with dementia. The other manifestations of neurosyphilis that we can look for on neuroexamination. So when you think that a patient has tertiary syphilis and you think that the patient likely has neurosyphilis, even before you order investigations, there's a couple of things you can do as you examine the patient. So one is that you can look at the pupils. So tertiary neurosyphilis, in a way, some patients can have what we call Agar-Robertson pupils. Now, these are pupils that are not going to respond when you put a light in it, but these are pupils that are going to respond when you're trying to assess for accommodation. Other things that you're going to have in tertiary syphilis is that some patients, like we mentioned, can present with tabes totalis. Now, in tabes totalis, you're going to have degeneration of the posterior cord of the spinal cord. And we know that this is what transmits our vibration sense as well as our coordinations. So just from your physical examination, you can try to assess for proprioception in these patients. If you have a tuning fork, you can try to assess for vibration. And if these patients have suggestive features, that in itself can be suggested that the patient could have neurosyphilis and prompt you to do some lab tests. When I talk about lab tests for syphilis, they could be specific and non-specific. Under non-specific ones, that's where we have our common ones, the RPR and the VDRL. The reason why we call these non-specific is because there are other things that would also give you a positive RPR and a VDRL. And these include pregnancy itself, certain autoimmune disease, patients that are septic, patients that have HIV and AIDS. All of these can cross-react with an RPR and make you think that the patient has syphilis. So as you screen these patients, and you find that the patient has a positive RPR, but you do not think that the patient could have syphilis, you should consider doing specific syphilitic tests. The ideal thing to do is that every time you have a non-specific test for syphilis being positive, you should always do a specific test like a TPHA and a TPPA just to make sure that you confirm your diagnosis. Treatment, drug of choice is always benzathine penicillin. Administration varies depending on which stage of syphilis you're treating. For most patients with primary syphilis, I think the house can agree that usually we give these patients 2.4 mega units once a week for 3 weeks. Patients with tertiary syphilis, ideally, we can give you benzylpenicillin, I think at high doses, 4 grams, 4 times a day for at least 14 days, and the administration has to be IV. Gonorrhea. So gonorrhea is also caused by a gram-negative diplococci bacteria. Okay, and the funny thing about gonorrhea is, or the interesting thing about gonorrhea is that it's also an intracellular bacteria. So already we know that it's likely to bring about activation of the CD4 type cells as well as the CDH type cells, as well as activation of gamma interferon. Gonorrhea has been implicated as far as STIs are concerned and has been attributed to patients presenting with a purulent or a mucopurulent urethral discharge. Patients may also present dysuria, and up to 50% of all women with gonorrhea can actually be asymptomatic. So just because a person does not have symptoms for gonorrhea doesn't necessarily mean they do not have gonorrhea. I think on the fourth point where we're saying that up to 50% of all women with gonorrhea may be asymptomatic, that's something we'd like to hold on to, because I think at the end of the presentation, we're going to make an application out. There's a couple of lab tests that we can do. Of course, we can do microscopy, looking for diplococci bacteria, we can do certain antigen tests, we can do culture and sensitivity, but where all things are equal, the investigation of choice for patients that are presenting with gonorrhea is actually PCR. So that's something that we can do. Treatment of choice, I think, even from the poll question, is ceftriaxone, IM, stat. So gonorrhea often develops resistance to antibiotics, I think, like was seen even from the pre-test that we did. So alternative drugs that can be given in addition to gonorrhea in the case where we think the patient can also have co-infection with chlamydia, also include doxycycline, as well as erythromycin. But if you note, the treatment of gonorrhea is a single of IM dose of ceftriaxone. The patient doesn't have to be on series of days of antibiotics, unless otherwise. Chlamydia is another cause of pus from the urethra. Okay, it can also give us symptoms of urinary frequency, urea, agency, as well as mucopurulent urethral discharge. Chlamydia is a fastidious organism, and there are various serotypes ranging from A to K, as well as L1 to L3. So when you look at the chlamydia serotypes that have been attributed to causing STIs, we're talking about the serotypes from D to K. These are the ones that have been attributed to causing STIs. Other serotypes can also cause other things like lung disease, as well as eye disease. In addition to the typical genitourinary infections, typical genitourinary symptoms that chlamydia can cause, it can also cause extragenital effects. For example, some patients can present with arthritis that we call arthritis. They can also have arthritis as well as uveitis. So if you have a patient who presents to you with urethral discharge, that is mucopurulent or purulent itself, they also have features of arthritis, they also have features of uveitis. It's possible this is a patient that's having reactive arthritis from chlamydia itself. Now, one thing for us to appreciate about chlamydia is that chlamydia, like the other organisms we've mentioned, is that chlamydia doesn't have a typical cell wall. It doesn't have a peptidoglycan layer. And remember, when we talked about ceftriaxone works by inhibiting the peptidoglycan layer. It works by inhibiting the cell wall. So that has a clinical implication, as we're going to see shortly. In women, chlamydia can cause cervicitis, okay? And mostly it's asymptomatic for most of the patients. Some patients can present with vaginal discharge, bleeding, dysuria, postcoital, or intermenstrual. As far as lab tests are concerned, PCR is also a method of diagnosis for chlamydia because it's fastidious, it's hard to grow, it's hard to culture. When we talk about treatment for chlamydia, you're going to notice that the drugs that you want to give, if you think a patient has chlamydia, you want to give them doxycycline 7 days, not ceftriaxone. If you could prove that this is pure chlamydia, you want to put them on doxycycline. Because you know, doxycycline works by inhibiting the ribosomal proteins in the cell. Ceftriaxone works by inhibiting the cell wall. We've said that chlamydia in itself doesn't have a typical cell wall, so ceftriaxone may not be as. So if you think a patient has chlamydia, maybe by clinical presentation, this is a patient with a mucopurulent urethral discharge, with arthritis and uveitis, and you have a strong suspicion that this is a patient with chlamydia, and you put them on ceftriaxone, you're not doing them justice, because the ceftriaxone has nowhere to work on the patient with chlamydia. So that's why we're giving these patients doxycycline 7 days. Alternative treatment that you can give if the patient cannot tolerate doxycycline, or the patient is in reproductive age, or they are pregnant, you can consider giving them azithromycin 1 gram once as a single dose. Trichomoniasis is caused by the parasite Trichomonas vaginalis. Clinical features essentially include a diffuse white and a clear typical frothy malodorous and yellowish green discharge. Some patients actually describe this as fishy discharge as well. It can also present with pruritus, vulvar irritation, and is one of the causes of vulvar vaginitis in the spectrum of diseases that we're talking about. In addition to this, some of these patients can also present dysuria because of the urethral irritation that arises. So as far as lab tests are concerned, we can do a wet mount microscopy just to look at the appearance of protozoa itself. Typical appearance is that Trichomonas vaginalis have a flagella, and that can be seen. There are also rapid antigen tests that can be done, and the management, tornadoes autograms, the oral start. In other patients, you can also give them tinnitus. Genital warts. So these are caused by human papillomavirus. Usually we are looking at types from 6 to 11. This is a virus, of course, it's a DNA virus, and it's an intracellular microbe, so to speak. So we know that this is a virus that is going to significantly depend on, for the body to clear it, you need activation of the CD8 cells, your CD4 cells, as well as activation of gamma interferon, as well as interleukin 2. So these are the main immune responses that we have. That is why we find that warts are actually more extensive in patients that have immunosuppression. In patients with HIV, they do not have a good CD4 response. They do not have a good CD8 response. So when somebody has HPV serotype 6 to 11 and a poor immune response as evidenced by CD4, these are patients that can significantly present with overwhelming warts. Clinical presentation, you can have induration with keratotic, flesh-colored or gray growths. Some people actually describe warts as lesions that look like cauliflower. I think most people are familiar with the appearance of cauliflower. So if you see something that looks like cauliflower in a patient, you'd like to think of warts, talking about serotypes from 6 to 11. And yeah. How do we treat these patients? Well, we can use podophyllin, which helps to dry the warts, then they can fall off. We can use cryotherapy, which involves freezing the warts with cold temperature. Salicylic acid helps us to dry them as well, and then they can fall off. Cauterization, we bend the warts, then they can fall off. Imiquimod cream is a drug that works by modifying how the immune response modifies the virus itself, and has also been used in the treatments of patients with genital warts. Then the other STI we're going to talk about, the last but not the least, is called molluscum contagiosum. Molluscum contagiosum is caused by virus. Of course, transmission is by close physical contact, and this accounts for the vast majority of transmission in children. So patients can actually get the virus and then later on present with manifestation. In adults, transmission is mainly through sexual contact, and you find that it's also a virus that also needs separation by CD4 and CD8 cells to actually control the virus itself. So in immunosuppressed patients, just like is the case for HPV, we find that molluscum contagiosum is also common and can actually it can be used to actually stage HIV itself. Clinical features, you have a dome-shaped, firm-rounded papules that has a dimple in between. The dimple goes downwards. That's the classic appearance. Firm, rounded papule with central ambidication. It can be pink or it can just follow skin color. Sometimes you can express it and you can get caseous material out of it. You can use the caseous material to do PCR just to compare the diagnosis. Treatment is a bit similar to genital warts, like we talked about. You can do curettage to remove them, cryotherapy, podophyllin, as well as IMI. So what are the complications of STIs? The virus STI we talked about. Because reproductive structures differ between males and females, we classify them too. So in males, you can have epididymal otitis, you can have strictures, you can have sterility, where we mean the patients are not able, they're not fertile. You can have fistula formation, bubbles, you can have arthritis, prostatitis. In females, you can have PID, sterility, bubbles, then you can have lymphedema, fistula, ectopic pregnancy, and miscarriages. STI screening. Basically, you want to screen partners of all individuals that you've diagnosed with STIs, whether it's chlamydia, gonorrhea, Trichomonas vaginalis, syphilis, hepatitis B, and HIV. All these diseases have to be sought for in sexual partners of the people that we're treating. If we treat the partner without treating the sexual partner, we're not doing much because the person will still get reinfected and still come back to the hospital. So remember, we mentioned that for female patients with chlamydia, 50% of them actually come without symptoms. So if you have a male patient who has chlamydia, you also just have to treat the female patient. So that's what we're trying to communicate. So asymptomatic females of male partners treated for chlamydia should also get treatment, regardless of their lab results, because you know that half of them are not going to be symptomatic. Then sexually active individuals should also undergo screening for syphilis, as well as hepatitis B. So what is the summary of our presentation today? STIs are common in the OPD, and patients, we actually see these patients. RPR, like we mentioned, which is readily available countrywide, is not a specific test for syphilis testing. And sometimes you cannot use RPR alone to decide whether or not you're going to treat a patient with syphilis. So this should always be coupled with a treponemal test, like we mentioned. HSV type 2 is the most common cause of genital ulcers, because we mentioned that they start as blisters, but eventually ulcers. Culture and sensitivity testing for Neisseria gonorrhea is very necessary if available, because there's been a lot of documentation of resistance to trials. So if you've been following the summary of the key points, this I'm sure should also answer all the questions that were raised in the post series. Thank you very much.
Thank you so much, Doc, for this wonderful presentation. I'm sure we haven't yet gotten the feedback from the network, but I should confess that it's a wonderful presentation. Yeah, so for those who were trained at some point in STI, you agree with me that this is a 5 days training, yeah, but we are trying to confine it within time now. And this topic is more clinical, because I know that sometimes we have our treatment supporters, the supportive staff, the facilities attending these meetings. So just bear with us today. It's more clinical, but I believe that learning is taking place. So maybe before we get some questions from the network, we are going to relaunch the course, yeah, and see if learning has taken place. So I think it's okay. So we are going to relaunch the course. We hope that the outcome will improve. So we've shared the first question. We hope to, yeah, we can see that, okay, voting is taking place. If you have a question, I will request that we also use the chat box. Maybe we may not have time to receive all the questions directly, so kindly use the chat box as well if you have any question. Thank you so much for voting. We are going to end the poll here. Oh, I can see that people are still voting.
People are still voting.
Okay. Okay, all right. So 5 more seconds before we end the poll. Oh, the voting rate is still poor. We are still at 44%. So we expect more people to vote. Yeah, we have a total number of 347 participants. So far, okay, thank you. We are going to end the poll. Okay, we are. Very much.
So that's the second poll.
So we encourage everyone to vote. Just give it a try. We want to see if learning has taken place. So far, 30% of the participants have voted. We can give you 10 more seconds before we end the poll. Just give it a try. We expect to reach at least 50% of the participants. We are still at 48% voting. 1 more percent before we end the poll. Okay, thank you so much. I think we can end the poll at this point. So,
Give me 1 second.
oh, sorry. Okay, all right. So, Kote, maybe you can launch for us the last poll question before we allow our presenter to give the feedback to the voting. So as we are waiting for the third poll question, we have, okay, all right, it has been launched. So we can start voting. Which antibiotic is currently suitable for treating gonorrhea in Zambia? Is it ciprofloxacin? Is it cloxacillin? Is it ceftriaxone or acyclovir? Okay. 5 more seconds before we end the poll. We are already at 52% voting rate. Okay, all right, so we are going to end the poll here. Yeah, so Doc, we can go back to we can go back to the questions.
Okay.
Yeah, so here we can see the result for the first poll question.
Yeah, so for the pre-test, can so for the first poll question before, the correct answer was Neisseria gonorrhea, and 69% of people got it. So we can just look the second time around, and the second time around, 81 people got the correct answer. So there's an improvement from 69 to 81%. Then for the second poll question, the correct answer was the correct answer to genital ulcers resulting from STIs are mainly caused by which agent? The correct answer was herpes simplex virus type 2. And 60% of people got the answer correct the first time around. Second time around after the session, I think this is the one that was relaunched. It wasn't properly done. But I think the first one went up to 80% before it was relaunched. The third poll question was, which antibiotic is currently suitable for treating gonorrhea in Zambia? We had a very split crowd. 59% chose ceftriaxone, whereas 38% chose ciprofloxacin. So at the second attempt of trying to poll this, found that the vast majority of people chose ceftriaxone, 93%. So that's from 59 to 93%, which is really good. So at least we know that going forward, when we go home, people are going to be giving people drugs when it is indicated. Yeah. I don't know what you think of the poll results yourself.
Thank you so much. I think learning has taken place, and the result can show that. Yeah, But right now we want to get some, to receive some questions from the network. We are going to pick maybe 2 questions. I can see already some hands up. So the hand from Maputo Simwinga, kindly unmute yourself and go ahead with your question. Are you able to unmute yourself?
Okay, I've managed.
Okay, thank you. Kindly go ahead.
Yes, thank you very much for the opportunity. And thank you very much, Doc, for the great presentation. My quick question is, what is the drug of choice to a neonate who has tested positive for syphilis, or who is exposed to syphilis, who has been exposed to syphilis? Thank you.
So penicillins are still the drug of choice, even in pediatric patients that have syphilis, because what we found is that syphilis has very good response to penicillins. So penicillins are still king as far as syphilis is concerned, unless Dr. Chitalu would like to add 1 or 2 things.
Yeah, Dr. Chitalu, are you on the call? Dr. Chitalu, are you on the call? In the meantime, we still have two more hands up. The first one is from SD Zimba, and the second one is from Jackson Mwewa. So as we are waiting for the feedback from Dr. Chitalu, SD Zimba, you can go ahead. And,
thank you so much. Thank you so much, Doc. I just want to find out the treatment for resistant gonorrhea.
Okay, so in an ideal setup, so like I mentioned, the drug of choice for gonorrhea would be ceftriaxone. That's the first drug we'd like to give. Alternative drugs we can give in place at doxycycline and azithromycin. But in an ideal place, we need to know what our cultures actually look like. So in a patient that has mucopurulent urethral discharge, mucopurulent genital discharge, we actually need to get into the habit of getting our pus swab and sending it to the lab. Yes, but where ceftriaxone cannot work, you can consider doxycycline, you can also consider azithromycin. Thank you.
Thank you so much, Doc. The last question. We expected a question from Jackson Mwewa. You can go ahead. Are you able to unmute yourself? Jackson Mwewa. Okay, all right. So we have received some comments in the chat box. I would like to mention that the registration link has been shared in the chat box, so we hope that each one of us is going to register. Kindly register, that would be great. So there is a feedback from Michael Piri saying that I really wanted to know how to register. I really wanted to know how to register. Are you able to see the comments?
Oh yeah, so he's saying that he really wants to know how the register we sign in is used, because last time someone mentioned that it can be used to actually get CPD points, and he wrote an email requesting for attendance and get that feedback. So the registration that people do online, is there a way of actually the sessions that they get, can you convert them to CPD points so that they can use them to renew their HPC license? I think that's the main issue.
Yeah, so I think we come back to that at the end of the session.
Okay.
Yeah, so there's a question here, does ceftriaxone have any activity against that?
Okay, I think we mentioned that partly in the presentation. So ceftriaxone is a broad spectrum antibiotic that works by inhibiting our cell walls. Now, chlamydia doesn't have a typical cell wall in itself. So it doesn't have a peptidoglycan layer. So because ceftriaxone works by inhibiting cell wall formation, in a bacteria that doesn't have a cell wall itself, it's pretty much, that bacteria has a natural resistance to ceftriaxone. So that is why for patients that we think have chlamydia, the ideal drug of choice that we can use is doxycycline. We can use azithromycin. The reason for those two is because these two drugs do not target the cell wall, but actually target the ribosomal enzymes that are going to stop protein synthesis, this bacteria, and make it. So that is why we're not encouraging the use of ceftriaxone in patients that have confirmed gonorrhea. However, where you think that a patient has gonorrhea with chlamydia, or where you cannot prove that this patient does not have chlamydia, it's not harmful for you to mix the two. So some people can give ceftriaxone with doxy, and some people can just give doxy alone, because we know that doxy can also have activity for gonorrhea.
So we have a number of questions in the chat box. I will request that our experts on the call maybe try to answer some of these questions. I'm unable to go through each one of the questions because of the time. We just pick some of them, but we have Dr. Chitalu on the call. Maybe you've managed to go for some of them, you can provide feedback. Apart from Dr. Chitalu, who is one of our experts, the panel also have Dr. Mundia. If you are on the call, maybe you can pick one or two questions from the chat box to provide feedback. So
Hi, Doc.
Hi, Doc. You can go ahead, please.
Okay, maybe Dr. Mundia wanted to get some of the questions.
Yeah, thank you, Dr. Mundia. You can go ahead.
If she can take, I can get some.
Good afternoon.
Good afternoon, Doc.
Sorry, could you kindly read out the question that you'd like me to respond to?
Okay, all right. So let me just go through. There's a question here. How do we continue receiving? This is about the link. What is the latest? What the latest management of PID? This question is from Monday. And there's another question, what the period of giving ceftriaxone in gonorrhea?
Okay, thank you. Those are interesting questions. I think I'll start with the gonorrhea question. So it depends on the approach of which we want to look at. If you're looking at syndromic approach, would advise that you manage all the three common STIs. So for example, whether a male or female has presented with either urethral or vaginal discharge syndrome, you have to cover for both gonorrhea and chlamydia. So like Dr. Teddy has mentioned, gonorrhea, our first line is ceftriaxone. Initially in the previous guidelines, we're using 250 milligrams of ceftriaxone, but now we have increased the doses to about 500 milligrams IM start. And then also you have to cover for chlamydia, where our first line, the use of azithro. But I'd want to mention that there's a concern for resistance for azithro, because a lot of patients are able to get azithromycin off the counter. So we have to take that history and try and establish whether there are concerns of resistance. So another option which you could use are drugs like doxycycline, which is taken at 100 milligrams twice a day. So again, gold standard of confirming your gonorrhea or chlamydia is cultures. So there are certain facilities like UTH that are able to do the rapid kit tests for gonorrhea and chlamydia, but confirmatory, you will need to proceed and do your culture, get your culture results. For anybody who will present with genital ulcers and you're using your syndromic approach and you're not able to test for either syphilis or HSV, again, you need to cover the patients with benzathine penicillin, which is a start dose of 2.4 mega units IM stat. And then also you need to make sure that you cover for HSV. So that's just an approach to managing the 3 common STIs, inclusive of HSV. In management of PID, again, we have to be very careful when we make a diagnosis for PID. Of course, you need to ask for certain symptoms, lower pelvic abdominal pain, especially during sex. Most of the females will give that symptom. Of course, again, on examination, they will have cervical motion tenderness. But then also when you do have this type of scenario, you would want to also screen for all the STIs. And so also PID, you have association with trichonoma vaginalis. You also have an association with bacterial vaginosis. So you will need to cover for those two. So for bacterial vaginosis, you give metronidazole. The recommended dose, usually we give a start dose of 2 grams PO stat. For those that are not able to tolerate, or if they've had a chronic discharge, there are times the metronidazole is given for a longer period, like 400 milligrams twice a day for 5 to 7 days. And then of course you have your triple antibiotics, where you give your doxycycline. You can use azithral as another option, but again, looking at duration, most clinicians or patients would prefer using the start doses. So you can give your 1 gram PO stat for azithromycin. So PID really has to cover your management of PID. You have to cover a broad spectrum of STIs if you're not able to investigate. Again, very important, you do your swabs, high vaginal swabs, for what we call wet mount. It's a microscopic investigation. It doesn't take long. You can also request for gram stain to give you an idea of what you might be dealing with. So that is what I would advise. Thank you.
Yeah, thank you so much for that feedback, Dr. Mundia. Dr. Chanda, I know that you picked some of the questions.
Yeah, thanks for that feedback from Dr. Mundia. Am I clear? Audible enough?
Yes, you are, Doctor. Yes, you are. You can go ahead.
Okay, maybe just answer 1 or 2 other questions that were raised. Somebody was asking about, what's the best way to differentiate gonococcal and chlamydia? From symptoms, it's very difficult, and I think Dr. Teddy highlighted that you can have co-infections occurring with the 2 and giving a discharge. So from the clinical symptoms, it's very difficult. That's why you need really to do your NAT to differentiate the 2. And somebody asked about chancroid. So usually the cause of chancroid is Haemophilus ducrei. So you find that you can treat, it's gram negative. So your treatment might be just something that cover for gram negative. So your ceftriaxone will actually be able to cover for that. Okay, I think some of the questions have gone away. Then there was a question about metronidazole. I think we know it's safe to use in pregnancy. I know there are concerns regarding miscarriages in 1st and 3rd trimester, but you can still use the drugs. There was a question to look at, I think there was an answer regarding the resistant gonococcal management, which was given, as well as Cipro. There was a question regarding HIV positive patients and RPR that's positive. So we do know that it takes quite a longer time for HIV positive patients actually to have clearance of the rapid plasma reagent. I think it can go for quite a longer time. That's why we want to monitor, especially those of a positive RPR, if they're HIV positive, to beyond actually a year of follow-up. So you might need to follow them for quite a longer time because they take quite a longer time to clear, especially if they're HIV positive. And really for HIV positive patients, you want not just to look at the skin lesions, but also to see if they have any CNS lesions. I know somebody asked a question regarding RPR for diagnostics. I think in the new guidelines, you probably see something regarding what's called reverse or algorithm for diagnosis of syphilis. So traditionally what we do, because in our setting, you can get a false positive RPR from malaria, pregnancy, sometimes TB. You might need to confirm it with what's called a specific treponema test. That's where Dr. Teddy mentioned about treponema hemagglutinin assay or TPH8 or TPPA. So those are the ones you use to confirm. So sometimes in those who are able to, you can go reverse. You start with your TPHA and goes to the RPR. And that's very key as some of the patients take time to form the positive RPR, especially in early syphilis. Then maybe I can take two more. The other question was actually about partner testing, which is very key. Some patients present with repeated episodes, could be just because of re-exposure. I think Dr. Singini raised that point. I think there was one more question I wanted to address. And then, yeah, I just wanted to also highlight an issue of benzathine penicillin. Really, it's like a depot effect that you have when you give that shot, and you know it will last and give you a half-life almost up to 21 days plus. So that's why we give the that repeated dose or that depot effect or the IM route that we give for the benzathine. I think I've addressed the last question, which looks at how to interpret the positive RPR. There was a question on
Dr. Chitalu.
Yes, I think I should there.
In the interest of time, I will suggest that some of the questions be answered in the chat box because we need to move on to the case presentation. We really appreciate the feedback from the network that's showing the relevance of the topic. I think toward the end of the question, we need to answer the question. We have a guidance on how to manage STI because it seems this topic is quite relevant. People would like to know more about how to manage these conditions. I think we come back to that toward the end of the session. So do we have Kabwe Women and Newborn Hospital on the call? Dr. Margaret Lubasi, are you on the call, please?
Good afternoon. Yes, I'm on the call.
Good afternoon, Doc. So over to you. Kindly take us through the case presentation.
All right, thank you. Good afternoon, network. For today's case presentation, I'll be your presenter, Dr. Margaret Lubasi, medical doctor by profession, presenting from Kabwe Central Hospital in Kabwe District, Central Province. Next slide, please. So for today's case presentation, the demographics are as follows. It's a case of VS, male, 43 years old, whose residency is in High Ridge here in Kabwe. His past medical history, there was no history of diabetes, epilepsy, sickle cell, asthma, or hypertension, but there was positive history of being RVDR since 2018. The drug history, the patient was only on ART, the regimen TOD with poor compliance. On the history of presenting complaint, this patient presented to us with a 1-week history of a generalized body rash that is said to have been pruritic, a history of a non-projectile episodes of vomiting. The vomitus was said to be yellowish in color with generalized abdominal pain. On their socioeconomic history, this patient is married with 4 children, works as a taxi driver, positive history of smoking, and positive history of alcohol intake. On physical examination, which was on the 21st of February 2023, the general condition, the patient was stable. There was no pallor, no jaundice, no cyanosis, but the patient was febrile to touch. The examination of the chest was clinically clear. Patient was not in respiratory distress. CVS, cardiovascular system, S1 and S2 were head and regular. The abdomen, on palpation, the abdomen was soft, not distended and non-tender. On the musculoskeletal system, there was a generalized macular papular rash. And on the vital signs, his saturations were 97% on room air, respiratory rates at 22 breaths per minute, a temperature of 39.5 degrees Celsius, a pulse of 115 beats per minute, and a random blood sugar of 8.9 millimoles per deciliter. So for our investigation of note, on the day of admission, on the first day contact with the patient, this patient was seen in our outpatient department. So the samples for full blood count, DC, the liver function test, urea and creatinine were ordered, and the CD4 count and viral count were ordered and collected. But as this patient was on the ward, these labs were followed up, and unfortunately, the samples had been misplaced. So that's the challenge that we faced, and the samples had to be recollected. So for treatment, for RPR, this patient presented with RPR that was done at the local clinic where he was referred to our facility, and it was reactive. A sample was collected at our facility. So for treatment, the patient was given 2.4 mega units of benzosine penicillin IM, and he continues with his ART regimen on TLD. For our questions as a facility, our first question, what measures can help with early identification of sexually transmitted infections in people living with HIV? And for our second question, is routine screening of sexually transmitted infections in people living with HIV recommended, or it might amount to some amount of discrimination? Thank you.
Okay, thank you so much, Doc, for the case presentation. So we understand that this is a man who is 43 years old. There's no history of epilepsy, no history of diabetes. Patient has been on ART since 2018. And the patient, I came to the facility with, was unwell a week ago. And he presented a generalized body rash with a history of non-projectile episodes of vomiting, yellowish in color, and generalized abdominal pain. So this patient is married, a taxi driver by profession, is exposed to alcohol and cigarettes. But when we look at the general condition, the patient is stable, the chest is clear, and the cardiovascular system, S1 and S2 are aids, but they are regular. What is more important here is to notice that when you look at the vitals, the oxygen saturation is at 97% on O2, and the respiration rate is at 22. When we look at the investigations done, we can see that this is February 2023 when the RPR was done, and it was reactive. The patient was commented on benzosine penicillin. And I saw one of the patients in the chat box saying, how often should we? I think it was the routes of administration. Yeah. So here, benzathine penicillin was given. The patient is on TLD. So these are the questions from the presenter, the facility. But before we go into providing answers to the questions, are there questions we would like to ask the facility, maybe where you feel that the case is not very clear? So kindly raise your hands so that we can give you the opportunity to ask the question to the facility for more clarity of the case. Any questions from the network? SD Zimba, you can go ahead. Kindly unmute yourself, SD Zimba.
Yeah, thank you so much, Doc. My question is, what was the main reason for referral from the local clinic to the hospital? It was not mentioned.
Okay. Thank you for that question. Is there any other questions from the network to the facility before we provide answers? Apparently, there's no question from the network. So, Dr. Ubasi, you can take it up.
Okay, thank you for the question. So of note is that prior to the patient seeking medical aid at the health facility, the patient presented with episodes of vomiting and abdominal pain after intake of alcohol. So apart from the RPR that was found reactive, we were also managing this patient for acute gastritis.
Okay, thank you so much, Doc. So let's look at the first question. What measures can help with early identification of STI in people living with HIV? So this is the first question from the facility. Do we have some response, a response from the network? Before we give chance to our experts to respond to this question, any volunteer to take it up? There is a question in the chat box. Dr. Lubasi, are you able to see the question? You can take it up, please. In the meantime, I'm going to allow Dr. Sinkonde to proceed with the question.
Okay, so in the case of the Treponema pallidum hemagglutination, I do not believe that that test is available in our facility, but we can still find out from the lab. But what we have for screening of syphilis is RPR.
Thank you, Doctor. Dr. Sinkonde, can you proceed?
Thank you, Dr. Onoya. It's a very good presentation and an interesting case. Kudos to the presenter. I think just trying to maybe add something on the first question, what might really help in early detection. I think this is something that we always emphasize of using the complete clinical evaluation form when you're seeing people living with HIV. You would be shocked that some of the patients that are seen as merely having a rash, despite being virally suppressed, when you examine the patient, when they bring the patient to you and then you examine them, you would find that the patient just have herpes zoster. And it's classical demarcation and all that. So sometimes people are not really using the clinical evaluation module for complete examination of the patients. So for us to improve in early detection, we need to emphasize on the importance of examining exposure of the patients and examining them in full. Over.
Yeah, thank you so much, Doc, for that relevant feedback. So we are going to get some feedback from the expert on the panel. So I did mention that we have Dr. Mundia, who is joining us from, I believe that now she's in Eastern Province right now. I'm not very sure, but she's not in Lusaka. Yeah, but Dr. Mundia is on the call. And we also have Dr. Chitalu. Here, our didactic presentation, Dr. Teddy is still with us here. So Dr. Mundia, would you like to provide your feedback on the first question?
Thank you once again. So just a correction, I'm in Southern Province. I'm in Monze currently.
Oh, thank you.
So the measures, so like I mentioned, a good history taking is very important. So you need to ask about high-risk sexual activity, number of sexual partners. Of course, those questions should not be asked in any discriminative manner, but it will give us an idea of whether we should be worried about STIs or not. So the reason why there's an emphasis on STI screening in people living with HIV is because, you know, untreated STIs like syphilis, the progression to neurosyphilis is faster compared to one who is HIV negative. Again, depending on which facilities or where the facilities we're at, our approach to early detection is based on what we are able to do at a facility. I'm currently at one of the facilities where we're actually discussing detection or identification of STIs. I know the easiest we can do is a syphilis, which is the RPR, but then again, that is not enough to confirm whether that is an active or acute infection or primary infection. So we still have to focus on syndromic approach in as much as we want to go the diagnostic way. So where things are impossible, syndromic approach will be the best way. But history, again, history taking is the best way to try and identify what STI we might be dealing with in the population that are HIV infected. Then again, we need to strengthen our systems in ensuring that our simple methods of identifying STIs has been put in place. I've mentioned things like gonorrhea, chlamydia, culture is the gold standard. So we have to ensure that every patient or client that comes in with any suspicion of STIs, we should always send culture to the lab. So all labs at every level in our facilities is able to culture these specimens. And then also simple things like microscopy. This is what I would advise on early identification. The second question is routine screening for STIs in people living with HIV recommended, or it might amount to discrimination. It would not necessarily lead to discrimination, but of course it would help, like I've said, prevent things like neurosyphilis. So screening has always been recommended in this population, and all of you, I'm sure those that are in the ART facilities, you have seen on the ART forms where we do ask whether a client has been screened for STIs. I heard Dr. Chitalu mention something about pregnant women. That is routine besides HIV testing in antenatal clinics. So it is part of routine testing services at every point in our ART services. So all facilities should include it as routine. And again, as we talk about management and screening for STIs, let's make sure that we do not ask our patients or clients in any discriminative manner. The good thing about STIs is they are all curable. Most of them are all curable, especially the most 4 common types. So we can treat and we can prevent complications from syphilis. We can prevent complications from gonorrhea. Thank you so much. Over.
Thank you so much, Dr. Mundia, for that contribution. Dr. Chitalu, do you have something to add on before we get back here with our didactic presenter?
Yeah, and maybe I can just add on to question 2. I think there's a very critical interaction between most of the STIs and HIV. And we do know that when we talk about combination prevention of HIV in terms of transmission, we need to remember the STIs as well. Some of them might impact transmission of HIV. But also we know that HIV can impact recurrence, especially like HSV. So there's a critical role and interaction. But another aspect you can look at is when we think of STIs, these are sexually transmitted infections. Not soft tissue infections, no, but sexually transmitted infections. And we need to think there are some that are preventable and some that are not preventable. Some are curable and some are not curable. I can just say most of our focus today was on the curable ones, but also there are preventable STIs. When you think of things like hepatitis B, that's an STI as well. That's preventable in terms of using vaccines. So we need to know and we need to screen for STIs because some are treatable and curable and others are actually preventable. So in the era of where we're using DTG, most of our patients, what will come with is STIs, NCDs, and the suppressed viral load. So in that regard, it's very, very important that we routinely screen for STIs in HIV positive patients. And those who have STIs, let's also screen for HIV. So it's a bi-directional screening, I would say, in such patients. I think that's my contribution on that question too.
Yeah, thank you so much, Doc, for that contribution. We really appreciate it. As I said, we really appreciate your feedback in the chat box. Been unable because of time to provide feedback to each one of the patients, but Dr. Teddy had time to go through some of them. Doc, would you like to provide feedback to some of the unanswered questions? There is this feedback from Dr. Singini saying that I noticed during practice that men were the only ones presenting with gonorrhea, and we would confirm it using the rapid gonococcal antigen test. Women, on the other hand, generally tested negative, except for one. Partner treating is very important for that reason. Thank you so much, Dr. Singini, for this feedback. Dr. Teddy?
Oh, yes, there was just, I think, a clarification on someone who was asking whether does it mean we've stopped treating patients with benzathine penicillin once a week for 3 weeks? No, that's not what we're saying. So that treatment is reserved mainly for primary syphilis. So in patients that have primary syphilis, that is the treatment of choice. We give benzathine penicillin once a week for 3 weeks continuously. I hope if you're still there, you've got that. But for neurosyphilis and secondary syphilis, treatment actually varies depending on what exactly you are treating. I think most of the questions have actually been addressed in part or in whole by the expert committee. I think most of the things have been touched, unless there are any pressing issues. I've seen there's an extra comment in the chat.
Yeah, there was, I know that we do have SOPs in the facilities.
Yeah.
Yeah, but we have an updated guideline on how to manage these STIs. Looking at the number of questions, to be good to, I don't know, I'm not very sure that all the facilities has got SOPs, but we have a guideline.
I think we're getting there. The new guideline actually has information on management of hepatitis B in addition to HIV and the other sexually transmitted diseases that have been there. But as far as chlamydia is concerned, RPR is concerned, I think the message is what Dr. Mundia actually said. I think in our setup, we're better off treating syndromically because it's not in every facility where you'll be able to actually confirm that this is chlamydia and there's no gonorrhea, or this is gonorrhea and there's no chlamydia. So I think the syndromic approach is the best approach that we can treat for now. I think it's what most people refer to as triple therapy. Most people are familiar with that. But what we want people to remember is that as far as gonorrhea is concerned, you want to put the patient on ceftriaxone. As far as chlamydia is concerned, you want to put the patient on something like doxycycline or azithromycin. But like mentioned already, because of COVID and the abuse that was there with azithromycin, you might consider taking that with a pinch of salt. And that is why the emphasis is that the gold standard for all these patients is that we should culture them so that we can know what they're actually sensitive to. I think those are my suggestions.
Okay, thank you so much, Dr. Teddy, for the presentation and the session. So we started with a didactic presentation, then we were taken through the case presentation. In summary, what can you have something to say to the network before we end with the meeting?
I think STIs are very common. And sometimes if we don't know what we're looking for, we can miss them. So I think the take-home message would be, let's not forget our history, our sexual exposures when we're seeing these patients. A good history is important. A good physical examination is also very important. Like we mentioned, the neurosyphilis, there are certain things that are a bit specific that you can pick up on examination. And of course, let's make it a habit of treating both the patients and their sexual partners. I know that is not always easy to do because you literally have to ask your patients to trace all their sexual contacts so that they can also be treated. Otherwise, your efforts are just being wasted. So let's try to have a holistic approach in the care of our patients, not just relying on our tests that we are able to do, but we should have a high clinical suspicion from the history, examination, and once supplemented with the tests that we're able to do, actually come up with a good management plan of the patient and their sexual contacts.
Thank you so much, Dr. Teddy, for that summary. I'd like to thank our experts, the panel, Dr. Mundia, and also Dr. Chitalu. So I will request that for those who are not registered, kindly go in the chat box. The link has been shared so that you can register before we end with the meeting. Also, I would like to give thanks to the Kabwe Women and Newborn Hospital for presenting this case. So from the comment from the experts, are you satisfied with the answers from what we received here? Are you able to provide quality care services to this patient?
Thank you so much to the feedback given to us by the experts. We've noted down all their additions, and thank you to the network for the questions and additions.
Okay, thank you so much. Okay, network, thank you so much for attending this meeting today. For the chairing today, it was Dr. Onoya, HIV/TB medical mentor under the Usara Provincial Health Office. Thank you, bye-bye.